hope you had a nice sleep yesterday. And I had a good one yesterday. I was a bit exhausted, but a good one. Well, what I'm going to do in the coming few minutes is try to share with you our experience in reaching the target of measles, rubella, and congenital rubella syndrome elimination in Oman. And I believe these sort of experiences that I'd like to share with you not only provide you with data how we have reached to that targets, but also based on these strategies that we have adopted, we were able to almost reduce the mortality and morbidity of these diseases among pediatric age groups as well as for the adults. So as I'm going through my talk, I'll be starting with a bit of background, status of measles, rubella, and congenital rubella elimination in terms of numbers and where are we and what are the strategies adopted, what are the lessons learned, and finally the conclusions and summary and conclusions. Well, for those who were not here yesterday, just to tell you where I'm coming from Oman. This is Oman, located southeast of Arabian Peninsula, and we have a border with United Arab Emirates, Yemen, Saudi Arabia, and we have a long coast which is facing the Indian Oceans over there. A total population in Oman around, as of last week, was 5 million, out of which 45% are non-Omani, non-locals. So we have a lot of non-locals coming mainly from India, Pakistan, and then other kind of from Philippines as well. We have a lot of population. So you need to understand in that context, when you are really reach the elimination, and we have a lot of influx coming from country where the measles, rubella still exists, so how the challenge to maintain that. So it's not easy to maintain in a country that have that sort of dynamic of populations. So the story started sometime in as early as 195, where our region, Eastern Mediterranean region, adopted the measles elimination by 2015. And we in the country, we have adopted elimination of rubella and congenital rubella by 2010. So this is our targets for eliminations. And we have adopted 4 strategies. These are global strategies for measles and rubella elimination, which included achieving a high population immunity, with at least 95 coverage with 2 doses of measles and rubella at national and every district levels through routine immunization or as well as supplementary immunization activity wherever needed. You have to have a strong case-based laboratory surveillance in place and proper case management as well as community engaged in these sort of activities. So these are the 4 strategies that we have adopted towards elimination of measles, rubella, and congenital rubella syndrome. And elimination defines as, for the measles, rubella, 0 endemic cases of measles, rubella, and are reported no endemic viruses transmission for the last 3 years or more in the presence of very, very well-functioning nationwide measles, rubella case-based surveillance system. And for the particular for the rubella and for the congenital rubella syndrome, we without the occurrence of congenital rubella cases associated with endemic. This is particularly in relation to rubella. Well, so let us go strategies by strategies and see how we have achieved it and what sort of activity that we have done. We have done a catch-up campaign in 1994,
covering all the age group between 12 months to 18 years. This is 18 years. And the coverage were 1994. And we have introduced measles, rubella containing vaccine into our schedule. And our schedule went into a number of changes, but the last one was in October 2000, and we have introduced MMR at 12 and 18 months. So this is, as of now, we have these two vaccines more than, I could say, 8 years at these age groups. And we have adopted a fever and rash case strategy. So wherever we have fever and rash cases reported to any primary health care, automatically we consider these could be measles or rubella, and we subject them to serological confirmation by IgM ELISA. For every case, we screen for both measles and rubella IgM simultaneously. And the system is very well established both for public and private sectors, and it is a mandatory reporting, and the screening is free of charge for all these cases that are taking place in qualified lab at the central level. We do have what you call a zero reporting, that every week for every site where the clinic are requested to send a zero reporting for fever and rash. And this is very important to make sure that all the cases being captured, as well as they were subjected to serology, in addition to proper case management and community management. Well, this is algorithm that is being adopted back home, and it very simple. It has the case definition over there, and it has all what need to be done at wherever the case being seen, and what other samples need to be collected, and where to be forwarded, and what are the data not to be collected, epidemiological data. And at the end of the day, there's a team where we go through every individual cases to classify whether this is discarded or serological confirmed or clinically confirmed. So this is a very simple algorithm that has been available in every clinic, so every physicians and pediatrician would be able to see and follow closely. Well, with respect to congenital rubella syndrome definition that we have adopted the WHO case definitions, and it is defined as any child less than 1 year with 2 complications of group A, which is these conditions, or group B, one of group B considered to be a clinically confirmed congenital rubella, and laboratory, of course, an infant with a positive test for rubella specific IgM or clinically confirmed. We do that to confirm all the cases. And some of these cases under the category of congenital rubella infection, where they may have only one symptoms or sign, but IgM positive. So this is considered to be as a congenital rubella infection. Well, and as I've already said, we subjected all our children to IgM tests. This is the results of what we have seen over years in an implementation of our strategies. We have earlier on, before I could say in 1995, we used to have a huge outbreaks of measles, thousands of cases. And the last one witnessed in Oman was 1992, 1993. And as I've already said, we had a catch-up campaign over there, and we have introduced the measles and rubella vaccine over there. We have introduced case-based surveillance, and as a result, and maintain a high coverage above 98% for the last, since 1996. Oh, this is high coverage. So Based on implementation, all of these, we were maintaining very low numbers of measles in Oman. And for the last 3 years, 2013, 14, and 15, we had 0 endemic of measles reported at the national levels. Well, this is just to show you the measles surveillance indicators that we have it. We were able to fulfill most of these global measles surveillance indicators. And notably, I want to show you over here to see the incidence of confirmed endemic measles per million per population, which is the latest definition of measles elimination. And you can see over here, we have reported a very low incidence rate, and the last 3 years, a 0 incidence per measles per 100 per million population. We are also collected samples for genotyping. Genotyping is very important. The genotyping provides us information on knowing the indigenous circulating of viruses, as well as we'll able to know whether some of these cases are important. So we have earlier on D4 and D8, D8, D8. It seems to be these D4 earlier was the indigenous we assume, and this D8, these are the imported cases coming from other countries. Well, rubella again, the last outbreak of rubella we had between 1992 and 1993, a huge number that accompanied with a number of congenital rubella cases over there. And as I've already said, we had a catch-up campaign and introduction of case base, and maintaining a high coverage of rubella, of 2 doses of rubella doses among the target population. As time went by, we have, as you see over there, we had a very small numbers reported endemic cases of rubella. And with respect to congenital rubella, the last case reported in Oman congenital was 2000, and we had 2 cases imported over there. And in fact, we had 1 case 2013, another imported case. So almost now I could say more than 14 years we didn't have any congenital rubella syndrome in Oman. And again, we were maintaining a high surveillance indicator criteria targets for all the rubella surveillance. This is to show you where are we with respect to our region So among all the countries in our region, Emerald region, we are among the very few countries maintain a 0 measles incidence per million population. We in Oman, Bahrain, and Palestine. But as you can see, other countries still experience a huge outbreak of measles. So what are the lessons learned? We have learned that the best way to maintain all your achievement is to maintain your high coverage. And coverage means you maintain immunity of your population, and this is very among the target group, and this is quite crucial. So we have sustained a high immunity profile. We were maintaining the vigilant and sustain the timely investigation of every individual case that we have it. This does not mean that we are not having imported cases. We do have receive, but wherever we notify imported, we have these vigilant contact tracings and make sure that all the contacts around it, they have received all the vaccines, particularly among the expatriate populations. We have a number of studies going on to the sero survey that we conducted among expatriates to make sure that, for those countries who are really coming to our country, whether they have been immune or not, and make sure that upon arrival, that one of the requirements is they have to receive the vaccines before entering the country. The idea is to maintain the immunity. Adult vaccination, particularly the healthcare workers, have been implemented now. I could say the 5 years for this has been quite important because we are the healthcare workers. Sometimes we believe that we have been exposed to the disease or we have been immune to the disease, but this is not the case. Particularly, we are having a lot of expatriate doctors who are coming from endemic countries. So as one of the mandatory for all healthcare workers, whether staff nurse or whatever it is, they have to have evidence of vaccination and immunity as well. And we are trying our best to make sure that the cross borders, particularly we have a huge border with Yemen, where the measles still are considered to be an endemic over there. So we very much try to be vigilant at the border to make sure that wherever who coming in are very much immune against the disease. Therefore, what I've tried to say that we have achieved the elimination of measles rubella, which is zero endemic. We have also eliminated the congenital rubella syndrome. And this is, based on these, we believe the best way of doing that is to maintain the system is very crucial. It's not a matter of vaccination. The structure of the system and all these pieces that you see over here, these are as a result of having these in place, this was the successful of our achievement of measles. So need to be there all the time. And we have published our experiences, congenital rubella syndrome-elimination experience in one of the journal, as well as measles elimination. This is the last year. By this, I would like to thank all the people that have done a job, and thank you so much for your attention.
So, any questions regarding the presentation from Dr. Al Awaidy? Any questions? Yes, sir.
Thank you very much for a nice presentation. I have two questions, in fact. Number one is the Omani people or the immigrant or the workers who are working in Oman, their children also included in your study for elimination?
Elimination is a countrywide. It means wherever who lives in my country, they are part of the system. And one of them, the system that we have, the vaccination is free for everybody. Is everybody, and is mandatory. So it means every child, for example, who comes to my country, when they go and proceed through the process of all these, what we call it, visa process. So if any child, for example, eligible child, the child, one of the thing that they need to do is to go and have an evidence in my country, evidence of vaccination. If they are missing any of these vaccination, we provide them. So the system is capturing everybody. Doesn't capture only the local. As I say, we have 45% of the population are coming from outside. And they, out of those, we have almost, I could say, 20% they're coming with their families. So they are, as long as they are living in our territory, they are part of the system. And we provide them the vaccine, they're free of charge. And one of the good things that we have this requirement, school requirement, is a very mandatory. No child is allowed to go to school without having evidence of all the vaccine. I'm not talking about measles, all the vaccines is a mandatory. If they don't have it, we provide them free of charge, as simple as that. So that really helps us a lot in reducing the immunity gap among different population who are keep coming in our country. Yes?
Please.
Yeah, the second question is about polio eradication. Did you have a plan or program of polio eradication, or is it already eradicated?
Oh, polio, the last polio we had was 1992. 92, the last polio. And polio eradication is every country's business. It's not only Oman, every country's business. And particularly when, you know the distance between my country and from India, and because of the movements, and we have all these plans of what you call it, preparedness plan, whatever it is. But for all these years, we haven't, even before the elimination of polio in India, we haven't had any cases from India. We had a lot of importation of cases from Yemen, but we haven't had any elimination of cases from India even before that. Yeah.
Second question.
Yeah, excuse me. I sometime worked in WHO surveillance program in Bangladesh and for a few years, and I know about these things. In Bangladesh, we started this MMR vaccine through WHO and UNICEF and Gavi project 3 years before, I think, or 4 years. What about Oman? When did you start?
We have started 1992.
1992.
1992, we have started fasting catch-up campaign covering from 12 months to 18 years, the fasting we have covered. And then we've introduced the vaccines, MR, 2 doses of MR. And the coverage, when we studied rightly. It means the coverage boosted 1995 from 1992 till now. We maintain. I don't want to go in detail how we maintain the coverage, because by itself is achievement, how we have done that.
Yeah, but I did a mistake. MMR was started in Bangladesh back 5, 7, or 8 years. But MMR giving vaccination to the 15 years old girls and above, you know that?
Sorry?
For rubella congenital syndrome.
Yes.
To get rid of those, the WHO has started giving vaccination of MMR, MR only, not MMR, to the adolescent ladies in Oman. What do you practice that? Do you?
We as I say that when we started catch-up campaign for everybody, and then MR introduced for the newborn, okay. And in 2000, because we want to go faster for the congenital rubella syndrome, we were giving rubella vaccine among postpartum. Good. So we have introduced now, because most of our cohort, most of them were, hardly they were already received the rubella vaccines. So we have hardly we give, but 2000 we give it for every postpartum. We're giving rubella vaccine. Right. The idea is to reach the target as fast as possible.
Okay, thank you very much.
So, question, please. No, please.
Just wondering about, you said when any child comes in with fever and rash.
Yeah.
Every single child has fever, rash, regardless. The clinical diagnosis you still investigate.
We don't look at the diagnosis. Our first entry point is fever and rash. I leave with the physician. You just diagnose whatever you wanted. For me, fever and rash, irrespective of the age, all ages. Fever and rash.
So they get serology?
They get serology, yes.
For how long? How long you've been doing this for?
We have started 1996.
And still going on?
Yes. And
that's
you need to understand the burden of that. That's a huge burden on our lab.
It is.
But this is the only way. So I wish I could show you the number that we screen on annual basis.
Yeah.
It's a huge number of
That's quite
screening
costly,
all age group. This means it gives us sort of reassurance that we don't miss cases. At the same time, it gives assurance that, because earlier on we were thinking going to very specific measles, rubella, we saw this is not enough. It will not take us to the elimination. It will just give us tip of
So is there a plan to stop doing this?
No.
Because we know
until verified.
Fever and rash are the most common presentation to.
We don't do this until we verify. WHO is about to go into verification process by the countries. They come to the country, verify. Once you go into the verification, say, okay, you have done good job, have done, and then maybe you could, lose up some of but we're not aiming to lose up that. That's the only way. That's to say, the idea behind it, you need to understand, we have a lot of expertise come in. Every year we have 5 to 6 imported cases. This means,
But still, if you're doing all the investigation, like immunization record or serology before they come in, you don't have to do this for every single fever and rash. That's my point.
We do both. One of the requirements for all the expertise before coming back home, okay, they need to be vaccinated, receive vaccine. But even though when they come upon arrival, they need to go into the checkup again back in our country. Again, we check it out. We make sure that they have received it. All age group, by the way. We don't focus on all age group.
Thank you.
Another gentleman over there.
Just behind.
Thanks for a good presentation. Regarding though the rubella is a highly concerned, it is a cause congenital anomalies. Regarding in our perspectives like Bangladesh and India, There is it is given in one dose in 9 months and onward, then 15 to 18 months. In also into the adolescence period. But some patients who are there's a suspected with TORS infections having rubella syndrome. Some are the IgM is positive, IgG is positive, IgM is negative. Though they are the evidence of rubella syndrome. One. It is one of my questions. It may occur.
Is it a question or a comment?
Because it looks like a comment.
No, you could comment. Okay,
No, it is my question. The IgG is positive, though the baby is suffering from the rubella, the neonate about suspected neonate of 10 to 15 months, 15 days, but IgG is positive in TORS infection, in TORS screening, but the baby is suffering from the rubella. One question, it may occur. Second question is, what are the seroconversion rate after two dose of MR vaccine to your patient? Have you observed?
Okay. The seroconversion have been done, I'm telling you, for those who really know about rubella, have been done tons of the country. It's very well known when you give it rubella MMR at 12 months, a seroconversion almost 98% onward. And if you give it earlier, for example, 9 months, you get almost 80%, 85%. So this has been documented. It's not something that I'm telling. Everybody knows about it. If you give it 12 months onward, and that's why we give it at 12 months, because we are gaining of these seroconversion as high as possible. Okay? This is documented. It's not something that I'm telling you. This is WHO documented. Everywhere have been documented. I couldn't get it. Your second question. If it is, we have to move. Maybe I need to sit with you face to face and go.
I think the question. Can I just verify? I think the question was: we discussed for congenital rubella, the baby is born and has positive IgG antibodies and not IgM. Baby has a clinical presentation of rubella, okay? And the question is, why is this happening?
Oh, so you may have, it depends on the age, because yes. Let me just go back to one of my slides. Maybe I didn't go very quickly. Come on, to see the laboratory. No. Okay, maybe that one. Okay. Usually, you see, the IgM usually would be the best to be collected between 0 to 6 months after the birth. That's the time, most of the time you had almost 90% of the IgM positive. Later on, you may not. So it depends on the timing where you have really collect the samples and see whether it's positive or not.
So if it's a first trimester congenital infection, when the baby is born, it will be an IgG positive and not an IgM.
Exactly.
So it's mostly regarding, as you excellently show on your slide, when the infection takes place. If it's a first trimester, probably you will only see IgG titles after the birth of the baby.
Yep. Okay.
Any other questions? Yes.
We have the isolated vaccination of measles at the age of 9 months, but usually the parent want to wait until the age of 12 months to get MMR. So that's why last 2 years in Vietnam we had a big outbreak of measles. How about in Oman?
Well, if you go back earlier, I mean, you know, the WHO still also recommend you could give it, MR at 9 months. You could give it, there's no problem. But you need to have a very good justification for that. we give justification. Our situation is we have, but I don't know what's the situation, but in some countries, because they keep reporting, because of low coverage of wherever they are attaining between 12 months, 18 months, so that means the immunity is not up to the standard, high standard, so they're still having a lot of cases, and most of the cases may be taking place between 6 months to 9 months. So by giving a vaccine at 9 months, now there is a SAGE recommendation, even you could go up to 6 months, but I don't remember, they've recommended up to 6 months you could give it, but in certain conditions. So still, the idea is, so I don't know what is your situation. The situation is based on your epidemiology, and then you need to decide it. What would be the best strategies to overcome, to hit the measles and rubella? If you're still having a lot of cases that is occurring, at lower age group, and you need to cover that, you could go lower down up to 6 months and start it to your schedule. But again, the best thing is to maintain high coverage. If you maintain, by default, you wouldn't have any cases at low age. As simple as that.
And how about the vaccination of measles in Oman? You do the vaccination of measles at the age of 9 months or 12 months?
No. We give it 12 and 18 months. 2 doses.
Thank you so much.
Okay. So 2 questions more, please. Comment.
Since, as I said, that I worked for many times in WHO from time to time, and as well as surveillance medical officer. So I know the inner things. Why don't we make a recommendation to WHO that, guys, please give us one uniform recommendation for every country? Because in Malaysia, I found they started IDP from 5-10 years, and they started in Bangladesh last year. OPV was given. I can see your measles protocol, MMR protocol, differs from Bangladesh MMR protocol. I don't know about India, Vietnam, maybe. So my suggestion is, let us recommend from this conference that we all think the WHO should give us a unified protocol in every country so that the outcome-based findings can be compared.
Okay.
Thank you.
Okay. And one lady over there, please.
Good morning, sir. In the Philippines, the EPI, the expanded program for immunization, actually recommends it at 9 months. However, because Philippines is hyper-endemic for measles with a coverage of about, immunization coverage about 78%. So in most private clinics, we may opt to give it as low as 6 months with an MMR at around 15 months. Now, if you follow the 9 months EPI of the Philippine schedule, the government schedule at 9 months, we then give the MMR at 15 months.
So even if you give it, as part of the recommendation of WHO, even if you give it at 6 months, 12 months, you need to give another 2 doses at 12 and 18, right? You need
give
to
a second dose at around the 15th month.
Exactly.
Okay, so if we have no other questions, first of all, I would like to thank the speaker, make a comment on what was proposed. The national vaccination schedule of each country, it's based mostly on epidemiology and also the resources, the financial resources of each country. So it's very difficult to have a worldwide schedule because, for example, in Europe, I never saw a case of measles since 1985. And we give 2 doses of MMR. We give a dose of MMR between 15 and 18 months and a second dose between 5 and 6 years old. So I think it will be very difficult to have a worldwide one only schedule of vaccinations for the reasons we discussed. I would like to come back to your presentation and ask about the strategy. You have an excellent strategy on vaccination in Oman, but what do you do for the adults? Do you have a catch-up vaccination program for adults?
Okay, if I've already said that, we had a catch-up campaign in 1992 between up to 18 years. 18 years, if you follow that cohort of 19 years, and now they are almost adults. These really adults, almost 35 years and 35 years old. So we have covered that very much, most of the adult. And so in addition to that, we are very much stringent in terms of vaccination among healthcare workers, because these are healthcare workers. And we have done earlier, sometime in 2 years back, we have done like sero-survey among adults, age group that we haven't covered them, to see the sero prevalence among those. And we found some of the group were very low, and we have done a catch-up campaign among those. So idea is, as you're going along, you try to figure out where are the gaps and tackle them effectively in order to minimize the immunity among different age groups. Yeah.
But what do you do for the adults? Do you have additional doses for vaccination for adults? For example, now in many countries of Western Europe and the Americas, they have additional vaccination for pertussis before every pregnancy.
No, that one, no, we don't do that.
So do you do at least a booster dose of DTP?
No,
you only do a booster dose of
you talk about
DT for the adults every 10 years?
Yes, that one, yes.
That you do that, yes. And nothing else? No booster doses on hepatitis B, for example, after 10 or 15 years? Nothing on this?
No. Hepatitis B don't do
so
any boosters.
I would like to make a comment here and say that if we really want to maintain this excellent program of vaccination that Oman has and other countries have, we need to increase the immunity between adults. That will be the turning point to eradicate the diseases. Because we have seen today, for example, that even 5 doses of pertussis doesn't give a long life immunity of the condition.
That's right.
Okay. So I think that what is more important to think about as pediatricians in the community is a schedule for follow-up vaccination for adult patients.
Okay.
Now, any other comments? Thank you so much for this excellent discussion.